everyone. First of all, I like to thank everyone just to be, it's almost 12 and staying awake and at least being present in the hall. So that's the thing. So I'll just be very brief about it. I'll just speak about 3mensio. So just a vote of hands. How many people do structural? Yeah. And how many people know how to do CT reportings? Okay, so I'll just be very, very, very basic. So, first of all, this is Gaurav. He's a clinical specialist from Merrill, so he's helping me with the CTs. So, we'll just show step by step as to how to analyze the CT for, TAVI analysis. So, basically, the first step is when you diagnose a patient having severe aortic stenosis, you advise the patient to get a CT done. So it's a CT iotogram protocol. So basically, right from the aortic valve morphology to the entire aorta up to the femorals and also the accessories, the subclavians, axillaries and carotids, they all need to be in a single CT and it has to be a gated CT. So once the patient gets that through a CD or through the software, we upload this on the 3mensio system and we have this data. So Gaurav, can you just put one patient, the simple, a tricuspid one? So this is how the 3mensio software looks. You upload that and you choose the aortic valve and this is what comes on to your screen. So you can stop me anywhere you want.
Sorry to interrupt. Why gated ECG for like gated CT images? Why do we need them gated to ECG?
Because the measurements are more accurate with a gated CT. That's the only reason. And in CT TAVIs, the valve annulus areas and perimeters, we have to be very precise with it. So that's the reason gated. And the chances of artifacts are also less. So after that, you can either do it manually or automatic. So we usually press the automatic button and this is how the first screen looks. So the screen on the bottom left, that's the aortic valve. You can see the three cusps and basically what you have to do is you have to get the annulus right. So how do you get the annulus right? So what's an annulus? It's an imaginary line in which, all the three cusps are in the same place. So what you do is you take one of the cusps, center it. See, Gaurav, just center it. Yeah, yes. So now go towards the LVOT. So we move down towards the LVOT and just where the valve this goes probably one frame below. Yeah. So this is where, you can't see the valve, the cusp. So this is where you'll put one of the dots. And you can just check it on the images above that it's at the lower level, at the annulus level. So simultaneously, we've done it for one cusp, we'll do it for the other two cusps as well. So you put the line across between in the middle of the cusp and then you go down towards the LVOT, down and this is where I can't see the cusp anymore. So I'll just place in a dot there. Yeah, so you can see it on the top screens. It's at the okay. Now do it for the third cusp. Yeah, center it. Yeah, and go down towards the LVOT. Go. One more. Yes. Okay. So now after this, your three dots, they are at the level of the three cusps. So just Gaurav, now just run the entire frame. Yeah, so we are going towards the aorta and now we'll go towards the LVOT. This is just a confirmation that in the single plane all the three cusps should go away. Yes, somewhat. So this is our annular level. Now confirm the findings and then you go on to this page. Okay, so he is rotating the annulus level and these are the longitudinal stretched visual images that you are getting. Now after we've confirmed the annulus level, what we do is we take the measurements, the minimum diameter, maximum diameter, we check the areas. So Gaurav, could you do that? So you can do it either manually by placing all the dots, or you could do it automatically. Yeah, you can adjust it slightly. So the 3mensio, the advantage of it is it calculates the area, perimeter and all automatically. The other softwares which are there, it's a bit more manual. So you can see that the area is 597 and the perimeter is 89.1. So any questions as to in which valves would you size it with area and which valves you would size it by perimeters? Perimeter wise, yes. So usually the balloon expanding ones, we usually check the areas, and for the self expanding we go by the perimeter derived areas. So also the other thing over here is we have to see what is the maximum diameter and what's the minimum diameter. So if there's a discrepancy, it's more elliptical annulus. So in that there are chances of paraval leaks and all as well. So at the annular level, you can see, at the site of the RCC, you can see a speck, white speck. So that's the calcium. Just show it with the arrow. Yes. So basically at the annulus, along with the measurements, you also need to see how the calcium is, where the calcium is, and depending on that, the valve choices might differ. So after this, we'll just do a bicuspid in which we'll show a lot more calcium and we'll discuss that in greater detail. So basically this is one part of it. You get the annulus, you get the annular measurements. After that, what else would you need on a CT report? Coronary heights. So Gaurav, can we go for the coronary heights? So you can see that the line, the green and the red lines over here, they are at the annular levels. So you rotate the image such that you can see the left main ostium, okay? And then from there you just take the line up and that's your left coronary height. Okay, so it's 13, 14, so it's good. Okay, and similarly for the right, so you rotate it until you see the ostium of the right, yeah, and then come up. So it is 23 millimeters from the ostium, so way high. Okay, so we've checked the annular measurements, we've done the coronary heights. What else should we do? What? Sinuses. Okay, so sinuses is where we find the the biggest diameters. So from the annular you come up till the time you see the sinuses. So measure the sinuses, Gaurav. So the left, okay, that's the right, 33, left 38 and not 38. So they are very roomy. So normally as a cutoff, anything 26, 27 or less, the sinuses are less. We consider them as small, and especially if the coronary heights are low, then these are the patients where the chances of coronary occlusion is high. So that is why you have to measure the sinuses. So we've done coronaries, we have done sinuses. What else do we do? LVOT. So LVOT is normally measured 3 millimeters and 5 millimeters below the annular plane. So as discussed today, more so in bicuspid. So you have to see what the LVOT area is and what the annular area is. So usually if the LVOT area is less, So while deploying the valve, there is a chance that the valve might embolize towards the aorta. So if the LVOT size is similar or more than the annulus, then we are quite safe. And also at the LVOT, we have to see if there is calcium, because that is where the risk of ruptures and perforations happen. So this is the LVOT. This is also quite roomy, so that's good. So we've done the LVOT, we've done the sinuses. We also see the STJ. So that's the sinotubular junction. So this is what Gaurav is checking at the sinotubular level. So you also have to see if there's any calcium specks over here, because especially in balloon expanding valves, the balloon usually can reach the sinotubular junction. It depends on how tall the sinotubular junction is. We actually had a case in which there was a circumferential calcium at the STJ, and we used a sapiens in which, while expanding, before the balloon could expand fully, because of the calcium, the balloon ruptured and the valve was partially deployed and the patient had to go for CABG, surgical correction. So STJ calcium is also very important. And the last thing what we also check is the ascending aorta and the tortuosity of the ascending aorta. Okay, so this is fine. And basically in the ascending aorta, we see what's the angle, we see how much of calcium it is, it gives a predictor of stroke as well. So that's that. So other two things which are important is the deployment angle and the calcium score. So we'll see the calcium score first. Gaurav? So how do we check the calcium score? The machine, the 3mensio will automatically, so this is the hockey puck image in which you just, it scores the calcium leaflet individually. So the red is the non, yellow is the left, and the purple is the right. Yeah. So you can see that the calcium scores of the individual leaflets is 300, 200, 300, and the total calcium score is around 900. So what's the severity of calcium score? So when do we say it's a severe aortic stenosis based on calcium scoring? Any idea? No. So any calcium score of more than 2000 in males and 1200 in females, that's considered severe aortic stenosis. So basically, if you have a discrepancy in the echo measurements, it's coming moderate to severe, and the stress echoes are also not very convincing, then it's simple enough to have these patients undergo CT calcium scoring. But the fallacy is, in India, a lot of the valves are very fibrotic rather than calcific. So many a times we have severe aortic stenosis, but the calcium scores are less. So if the calcium score is more than 2000, it is definitely severe aortic stenosis. But if it is less, it can still be severe aortic stenosis. And lastly, so this is the constructed image of the aorta, in which you can see the white echogenic thing are the calcium. So it will just give us an idea as to how calcific the aorta is, and how should we be more careful while putting the big devices across it, because there is a chance of stroke.
Sir,
yeah.
How do we solve the fallacy for Indian patients? Like if balls are, the calcium is less, it's more fibrous. So you're saying that calcium score may be low and the patient may still have severe aortic stenosis.
Yeah. So basically, So basically, aortic stenosis, it's the severity is not done by just one criteria. Obviously, you have to see the symptoms, you have to see the echo parameters, you have to see the CT findings. Many a times, if you can do dobutamine just to see, how the aortic valve is behaving. So it's not just one parameter, it's probably an amalgamation of things in which
Anything else that we look in CT for severity in addition to calcium?
On the CT specifically? No, it's just the calcium score. No. So that's that. And the other thing what we do is we get the deployment angles from the CT. So how do we get the deployment angles? So this is what Gaurav is doing. He is putting the arrow across at the mid of the RCC. So because in a coplanar view, the RCC cusp is in the middle, on the left is the left and on the right is the non-cusp. So, and then the machine automatically calculates it. So the coplanar view for this patient is LU 15, caudal 5. And it also calculates the angle of the aorta, so it's 45. So normally we would say that any angle more than 50, 60, it's a horizontal aorta in which the deployment of the valve can be a bit tricky and difficult. So yeah, that's it. So this is one aspect of it. Now other and probably even more important thing in CT is we have to look at the axis. So femorals, how they are. Anyways, so before we go on to femorals, any questions, any doubts on what else on the CT measurements? Yeah, you can say.
Cusp overlap view also.
Cusp overlap, okay. So cusp overlap views are usually not done for balloon expanding valves, but for especially for more importantly for accurates, we would need that. So cusp overlap, Gaurav. So in this, you have to take the two dots, merge them into one, so that this is the NCC and the left and right, they'll overlap. So this is the cusp, a bit more. Yeah, so this is the cusp overlap view. RAO 11, caudal 27. So usually cusp overlaps are RAO caudalish. Okay. Arvind, you were asking something?
Actually, no, I am interested in S-curves.
You were interested in?
S-curves.
Oh.
Basically, I have worked.
Yeah.
So the next part the next part is where I will be talking about only S-curves, because all the things that has shown can be shown in other softwares also. This is a paid software.
Yeah.
What is the cost of this software?
I think it's 3 lakh per year or what?
10 lakhs.
8 lakhs. Okay.
How many of people here are going to buy this?
So where I was trained in the UK, we didn't have this 3 mensio.
Yeah, that's
we
it.
used to do
So,
it on
so if you
Siemens
want
software.
to learn TAVR, or if you want to do anything in structural, you have to have a software like this.
No.
I'll tell you why.
So
The other thing is you can do it, but these company guys will come and sit next to you and you can do it.
yeah.
The only thing
So
is
that
you
is
don't,
how
will not
we
have
do
it handy. So you'll not have it handy.
This is very important. You will not have it handy. It's very important. We have to keep on looking at things to become specialist. You know, the difference between a specialist and a novice is he does the one thing for 10,000 times. You cannot do this thing 10,000 times if he is coming to you once in a month. If you have the software in your hand, you can look at one CT for 10,000 times. It will train you better than looking at 10 CTs 10 times in a year. No, it's not going to help you out. If you are really interested in something, you have to keep looking at it. These S-curves, if you keep looking at these S-curves, you will find things which have not been described yet. People are looking at it in certain ways. It's like, see, if you do something like an LED plastic, anything, any intervention, everybody has its own way of looking at it. You develop that because you are continuously doing it. We are being, deprived of this opportunity to learn through looking at the images again and again. So what I call it is like something like democratization of structural heart disease intervention program, where we have softwares which are already there in the market, which are free, where we can load the CTs and see them again and again. What I will like to...
But the same thing works there as well.
Yes.
All the principles what we told works.
So all these parameters are not there.
That's let me show you a software after this and tell me whether it is manual or almost automatic.
No. So here you can do everything manually as well, and all the softwares, even the other softwares, manually it's the same. So it's.
I have made a almost automatic version of it. That's what I'm going to show.
Okay, good. I have one. Okay.
So I am very much interested in these S-curves. The value of these S-curves is understanding everything in structural cardiology. The value of these S-curves is merging the views of an imager and an interventionist. The value of these S-curves is in understanding that whatever you are looking at on fluoroscopy, on TE, on transthoracic imaging, on CT scan, or on a structure of a heart from a mortuary, everyone is looking at the same heart. So if I am looking at the same heart, I should be describing it in the same way. The problem is, if someone is looking at the heart from a mortuary, he will be talking about something else. And somebody who is doing a TE, he will be talking about something else. And someone who is looking at a fluoroscopy screen, he will be talking about something else. That's the problem. Where somebody is saying that, go medially, go laterally. And you are saying, I am going up, I am going down. What are you talking about? Where is medial lateral here? The fluoroscopy screen does not have a medial lateral.
So actually now there are softwares which can merge the fluoroscopy and the TE images together.
First thing is, in your brain, you create maps which are pattern recognition maps which everybody understands. That's the first thing. Then you require something like, I have been using echo navigation since last 6 years. I have been trained with Dr. Shivkumar sir. I know echo navigation.
Okay. So disclosure, I don't sponsor 3mensio. So now we come on to the femorals. So femorals are as important as doing the annular measurements, because where I was trained, a puncture site was also dependent on the CT scans. So basically on the CT, based on the calcium markings, based on the bifurcation, where the femoral head is and where the femoral bifurcation is, you need to know where you are going to puncture using the ultrasound. So the CT helped us in, we could correlate what we saw on the ultrasound, what we saw on the CT, and then we used to puncture there. So how do you identify the femorals? So you will just put some dots on them. Yeah. So once you click, it automatically captures the femoral and the aorta. So you confirm them, and then you just put some dots. Yeah. And then it gets reconstructed automatically. Yeah. So once you have this, you check how much calcium there is, what's the size of the vessels, the tortuosity of the vessels. So what is your primary axis, what is your secondary axis, how the bifurcations are, is it a high bifurcation, is it a low bifurcation. So you'll come to know a lot of things from there. So this is the short axis view, in which he is checking the measurements. So usually blanket we can say anything more than 5.5 is good enough. Sometimes for better sheets, like for accurates, we are okay with even 4.55 as well. The 14 French eye sleeves. Sure. No. So size, blanket wise, if it's more than 5.5, how much ever calcium, I'm not bothered. But if the size is small and there is calcium, it depends on the tortuosity, it depends upon calcium as in not just how much calcium, like how much arc it is or how densely calcified it is, and then how tortuous the vessel is. So a lot of factors will come into play rather than just one thing. But yes, however calcific, if the lumen is 5.5 or more, it should be you're pretty much sorted.
Will you put a safety wire? When will you put a safety wire? To the contralateral groin or to the same groin? When do you expect complications?
So to be honest, I would never put in a safety wire up front. I'll do the punctures, I'll take the proglides, you have the wire. Now the thing is, it's very important that you don't lose access of that vessel. So until and unless I'm sure, I'll not take the final wire out. So if in that there is a complication, then you always have that, through that wire you can deploy something. Now, to be honest, we are trying to move away from bifemoral axis into one femoral and one radial axis. And instead of pacing on through the venous sheath, we're going directly pacing over the safari wire. And in UK, we had some cases in which we have done just single axis TAVRs. So just one femoral axis, no radial, no other femoral axis, and we've done that. So this is just to reduce the complications, because it was always said that you take the second femoral axis, the chances of complications on the second femoral axis are any which way is 3 to 5%. So why take it in a way? But yes, but then you should have a bailout kit with longer wires, with balloons which can go through the 6 French radial sheath, which are long enough, which can go up to the femorals. So just run it down. So when he is running down the stretched vessel, you can see the lumen, so which is quite good, no calcium, nothing much. He's coming up to the bifurcation now. Looks good. That's the access site. This is the bifurcation. So that's that. Any questions on this CT or anything in particular you'd like to ask? Then we'll move on to something more complex. No? Yeah.
In the mic, please. Mic.
Why the deployment has to be in the coplanar view, and why is it difficult to deploy the valve in a horizontal aorta?
Okay. So the first question, why a coplanar view? So what is a plane? So in which all the three cusps are in the and the same line. So the valve has to be parallel to the coplanar, to the annulus, because if we are deploying it at a different angle, and if your valve is not coaxial to the annulus, then rather than an 80-20 you would have a canted valve, as in it will be like on the left side it will be 70 and on the right side it will be 100. So you always have to deploy the valve in the coplanar view. Many a times what happens is on the CT we get some angle, but when we actually take the fluoroscopy, like we take the cine of the aortogram when the patient is in on the table, you find that the cusps are not aligned. Then you have to chase the right cusps and then get the coplanar view and then only deploy the valves, because otherwise your valve deployment will not be parallel to the annulus. So that's very, very important. So, and it's more so important for self-expanding valves than for balloon expanding. It can be very unforgiving. Okay. So this is the second one.
Yeah, bicuspid.
Yeah. Now we'll just do one bicuspid, so I'll just take 3 to 4 minutes. It will just show some calcium on it. So this is a bicuspid valve. Arvind is doing manually this time. Okay. So no raphe, a lot of calcium, type 0 bicuspid. You can see there's a lot of calcification on the leaflet. Just show the annulus fast. Over here, so usually in bicuspids it's very difficult to get the coplanar view, because instead of 3 cusps there's just 2. So you have to imagine there's a third cusp and then place the dot over there. And it's even more difficult when you kind of have this patients in the cath lab and get the coplanar view on the angio. So while Gaurav is doing the annular plane measurements, getting the annular plane, what I'll just like to specify is that it's not just the measurements, you have to see how calcific the valve is. And it's not just the calcium score which is important, or where the calcium is, it's important. It's also the morphology of the calcium that's very important. So let's assume there's a hard rock boulder of calcium on one end. Whatever you do, that calcium is not going to move. That valve will move on the other end. So you might expect complications on the other side. So if there's a big raphe at the left, the valve will move on to the non-coronary side and then you will have annular ruptures. Now let's assume a second scenario in which rather than a boulder of calcium, there's a streak of calcium which has spikes. In that, when the valve expands, the calcium spur might go on and hit and cause annular injury on the same direction. So it's just not the calcium score that you have to look at, you also have to look at where the valve calcium is and what is the morphology of the calcium and how thick that calcium is. If the calcium is mainly in the leaflets and less in the annulus and in the LVOT, then you might just get away with it. So, yeah.
Can you
That's
talk
it.
about something about sizing in bicuspids?
Sizing in bicuspid?
Yeah, that is very important.
Okay. So, sizing of the valves.
Yeah.
Okay. So basically, obviously, it's said that for tricuspid valves, if you use a self-expanding valve, you have to oversize by 20-25%, and for balloon expanding, 10 to 15% oversize. Now, because bicuspids are calcific, they don't tend to open up completely. Depending on what the morphology of the bicuspid valve is, if your sizing has to be less. So for balloon expanding for tricuspid, if you go for 10 to 15% oversize, for many very severely calcific bicuspids, you go for 0% oversize also. A few times we have gone for -5% oversize as well.
No, one question that I have is,
Sure.
you can have bicuspid.
Yeah. So this is in general. Now let's assume, so usually in bicuspids, the narrowest area is supraannular rather than at the annular level. So in those cases, you can get away with, it's preferable that you do a 100-0 placement rather than an 80-20 placement. So that the advantages of that are obviously, because it's above the annulus, the chances of pacemakers are less, because bicuspids are usually heavily calcified and they're prone for pacing. So you can get away with it. The second advantage is that because the narrowest portion is above the annulus, there's a better hinging, and you can put in a smaller valve and it can fit better.
No, so what I wanted to ask is,
Yeah, sure.
the area that you get,
Yeah.
what cross-sectional area do you take? Do you take the annular area or do you take the narrowest portions area when you are deciding to size the
The
valve?
lira
So
plane.
normally I take
That's what
three
they call it.
areas. One is the LVOT area, one is the annular area, and then from the annulus I come up and then I see the narrowest area. So if the narrowest area and the annular area are similar, I just go with the annular area. But if there's a lot of discrepancy, then there are two ways I go about it. I'll take the annular area and I'll just go with 0% of it, and I'll assume that it will be oversized at the level of the narrowest portion. But there are no specific guidelines as to what specific area you can take, but this is what I was taught. But this is mainly for the balloon expanding. For self-expanding, it's not that difficult, because there's a lot of leeway. So
You
it's
take the
just
shape, so there's not much risk.
it wouldn't matter much, but it's for the balloon expanding, it's definitely useful. Any other questions?
The calcium decide also which self-expanding valve you take.
So basically,
Would you put a portico?
So basic, pardon?
Ever put a portico in a bicuspid?
No.
So somebody showed it. Yes,
No. So
Portico.
So
We've
basically,
done porticos and bicuspids, but it got given a lot of paravalvular leaks.
exactly.
Yeah.
exactly.
So
So now the Navitor, which has come with an extra skirt,
Right.
in that people have done bicuspids, but with portico, it's really we've had a lot of trouble with porticos.
So normally, so basically there are four self-expanding valves. Hydra and portico, they don't come with the skirts, so the chance of paravalve leaks are more. The newer version of portico, as Dr. Ankur said, the Navitor is good. Accurates, usually we avoid it in bicuspids. You can still go put an accurate when there is a right-left fusion, but the non-cusp is okay. But still, I'm not very comfortable with it. And accurate specifically, if it's a very, very calcified valve, it's slightly difficult. And probably the choice of mine would be an evolute.
Because radial,
The radial strength is more.
just below it is Vienna what?
Pardon?
Yes.
Vienna.
Vienna valve. I haven't put any Vienna valve, so I won't be able
Somewhere
to
in
comment
between.
on it.
Somewhere in between,
It's somewhere between the accurate.
Portico is the least.
Evolute and portico.
Portico is the
This a
least.
spectrum.
Somewhere above is accurate, then Vienna, and then evolute.
So that is more of radial force
Right.
when it opens up.
So the radial strength and radial force is different. There is the opening force and the radial strength is different. The accurate has less opening force but a decent radial strength. Evolute has more opening force and a slightly better radial strength. Okay. Thank you, Gaurav. So
Thank
big
you,
hand
Meghav.
for
Thanks
Gaurav.
a lot. Thank you very much.
No.
Thanks,
And
Gaurav,
thank you, Gaurav, for waiting
for
with
staying
me
up
till
at
midnight.
12:15, I think. So, Dheeraj, let me answer your question. So, you asked, what do you look at the femoral? So, you see B square CS. B square is bend, bifurcation, calcium, stenosis. So, these are the 4 things you look at when you look at the femorals. It's not only the size. So, even if you have a good size, if you have a bad calcium, you might have problems, right?
You might have to do a peripheral IVL to get
Peripheral
your
IVL. So Dr. Bhavesh also, I think, if you were there, showed a
Yeah,
facilitated
I saw,
TAVI. We did
I saw.
recently now. Both
Yes.
of us were there. So we did
Yes.
a facilitated TAVI in
Right.
that case. So
Or
balloon
if there is too
dilated
much
and-
of a bend, you might have to go for a Lunderquist rather than a safari.
Absolutely. Straightens off.
Straighten up your
Straightens
vessel.
off. So when you feel like you go with the Lunderquist, but if you want to save money also, then when you're going in the wall, don't use a safari, use the same Lunderquist.
Right.
So 2 बार पैसा नहीं जाएगा.
Correct.
So otherwise you're short on budgets in TAVI and you use a Lunderquist and a Boston Safari,
No,
it's 50,000 and 35,
Lunderquist
40,000
is
gone.
10, 12,000 and safari is 33,000.
Absolutely. No, Safari is not 30,000, it's 50,000 MRP.
50,000.
Yeah.
Good.
Maybe for you
Okay,
it's
ठीक है.
35,000.
Yeah.
So we'll have to speak with them.
And one more thing is, have you ever encountered a case where the high bifurcation precluded a femoral axis? How
Lots
common
of,
is it?
when we started, especially. Yes.
So basically, it's with the advent of ultrasound, the chances of complications have gone.
So now with the Gaurish taking ultrasound, you want to talk?
No.
So Gauri showed you the cases we did in the in anesthetist corner. So all are sono guided punctures, and sono guided gives you stay away from the calcium, because what happens sometimes the proglides don't properly fit in when you have the calcium there. So that is one more thing.
The only thing which I'll add on to this is on sono. So basically, the CT will give you an idea if it's a high bifurcation. Now, the basic crux is the higher you go, there is a chance of retroperitoneal bleed. So we were told that when you see the long axis of the vessel, you'll see the vessel bifurcation. It'll go above and then it'll dip. So you have to puncture before the vessel dips. Otherwise, many a times when the vessel dips or just before it starts dipping, there are 2 things. You can take the puncture through the inguinal ligament. Yes, or you can go retroperitoneal as well. So if you go through the inguinal ligament, the thing which the sheaths might kink, but more importantly, the proglides will not take in. So the thing is, if the patient complains a lot of pain when you're putting the 6 French sheath in, always reconsider that you've gone through the inguinal ligament or no. So that is one, clinical thing which I have come across.
So my tip, because Meghav went to Liverpool, 2 years there, learned TAVI, the art, and people might not like us. We have already started practice. So it's difficult for us to go and come back. So practical tips. One thing is, when you use a proglide, don't use in a TAVI first. You do angiographies and angioplasties daily. So if you want to practice, not on angioplasties, do it on angiographies. I know it's costly, but somewhere or the other you have to invest in yourself, to learn the procedure. Because even if you're doing a plasty, suppose, and I know insurance will cover it, suppose your proglides don't fit in properly, you will have to keep on holding the sheath because you've given heparin, right? So angiographies are the best place to learn, not on TAVI. So what happens is, you get a TAVI case, there you are all gungo about taking sono-guided punctures and putting in proglides. No, don't learn on your TAVI patient. Let the proctor come, observe the proctor, do it on an angiography patient. That is how you learn proglides.
Most people don't dissect the vessel.
Yeah, that's one more thing.
Yes.
So what happens is, that's a very common thing what happens is, you have this, you want to make it big, you want to make the hole big. So what you take the artery forceps and try to open it. Don't go very deep. We have had cases where the operators have gone very deep and then cause the damage to the artery, and then your proglides don't fit in, and then there's bleeding, and majority of our complications are here. All the learning curve is here, because most of us are not trained to manage complications here. And this is not your 6 French sheath or 7 French sheath, this is a 14 French sheath.
So the tip is just take all your femoral plasties also sono guided punctures. It gives you a lot of confidence.
It should be #safe femoral rather than #radial first. That's how it is.
Radial, but whenever you're doing femoral, don't take a hand.
Yeah, taken this side.
Yes.
And always for TAVIs take 2 pro guys. If one doesn't click, the other one, at least takes in. At least in the initial learning curve.
Always. Arun, just 5 minutes. Give us 5 minutes.
It can. So many a times, you just take one pro glide and then see how the flow is. If the blood flow is okay, then don't pull the second pro glide. Just leave it like that.
So let me say a few things before Arvind starts in. There are a few, things which are there. So calcium, which Chirag told today, calcium can be at various places on the wall. Okay, so everything has a different meaning. Calcium at the annulus, annular rupture, paravalvular leaks. Calcium at the raphe, inappropriate expansion. Calcium at the belly, good, will hold your wall. Calcium at the tips, coronary obstruction. How high should be your wall? The wall should be as high as it should not get embolized, basically. So if you go higher, the coronary obstruction is higher. The younger the patient, higher, more problem that coronaries might not be accessible. Lower you go is more of the pacemaker risk. So that is one more thing. Sinus of Valsalva. How big is the sinus of Valsalva? Whatever you get is your annular sizing into 1.2. If it's more than that, it's a good sinus of Valsalva. Other thing is +5 is also good sinus of Valsalva. Sinus, the sinutubular junction, that's important, especially when you want to go to do a ball and wall procedure. So wall to STJ is one thing which you see. So that should be at least a 2 mm cutoff. Horizontal aortas, as Meghav told, that's also 60-70. Horizontal aortas, you have to be really, you have to keep that push. The first and the second operator have to have that kind of coordination before you deploy the valve. And then lower down in the periphery, as we've already discussed, it's the bifurcation, bend, calcium, and the stenosis. All the things you should look out for before you decide the valve. And small annulus valves, please don't go for a balloon expandable intra-annular valve. If you have an annulus less than 21, 22, I have burnt my hands doing that with the valve degenerating faster. I know because it comes cheaper, you will advise your patient because you want to do a lot of TAVIs, but anything less than 21, 20, please don't attempt it.
Don't put
Go for a supra
Merrill 20, 21 and a half, ever.